So this is going to be a fairly quick kind of view of the nation in terms of ESRD and CKD. So a lot of this data is based off of the USRDS, and what this provides is time trends in counts of new patients. So new patients coming to ESRD, both transplant and dialysis. And what you see is overall, it's over 100,000 new patients a year in the United States. The other point is that if you look here for the last several years, there's actually looks like it's plateauing a bit. So whereas there was a fairly sharp increase over the years, over the last several years, there's been kind of a plateau. And that's a little clear when you look at it as an incidence rate, meaning it's indexed to the population and also adjusted for age, sex, and race. And so when you do that, so this is a fairly complex figure, but these bars represent the incidence rate. And these lines, these vertical kind of thin lines, have to do with the percent change over the previous year. So when they're above this line, it means there was an increase. When they're below, there was a decrease. And what you can see is, again, it was increasing, some kind of a plateau, but it appears to have declined or at least stabilized the last few years. So something's happening there to slow down the rate of new cases. It's hard to know. We actually don't know exactly what's happening there. Is this something that's related to measures that have been put in place in terms of trying to improve the care of kidney disease, better use of medications like ACE inhibitors to slow down the progression of kidney disease? What's happening here, we don't know it precisely, but it's perhaps some good news. The other thing is the prevalence. So how many people are necessarily new, but are currently existing on dialysis or as transplant patients. And that is continuing to grow. This, again, is the percent change. So even though it's still positive, the amount by which it's growing is slowing down. And prevalence is really a combination of how long you're on dialysis or have your transplant and how many new cases are added. And we know the new cases added have slowed down or perhaps completely stabilized. So some of that drop in the percent change is probably related to that. Some may also be because patients are living longer, because you'll see in the next slide that mortality is also going down. But if you want a quick snapshot of numbers, we have over 600,000 ESRD patients in the U.S. right now, and a little over 400,000 on dialysis and about 200,000 transplants. Mortality rates. So mortality rates are coming down. Again, really good news. The rates are still high. So this is put as numbers per 1,000 patient years, but you can think of it in terms of percent. So back here in dialysis, it was about 25% of patients on dialysis every year would die. We're down to, about 17%. That's still very high, but it's certainly a big improvement. There's, again, we don't know exactly why it's getting better. Similar trends are seen in the general population, so some of this may reflect that, but perhaps it's a little steeper compared to the general population. So there may be things we're doing. One of the things may be improvements in vascular access. Certainly in prevalent vascular access, we're doing a better job in terms of giving people fistulas as opposed to leaving them with catheters. That could be one potential contributor. And then costs. So I don't think we need to worry about the different divisions here, but the point is that the costs have been going up. And we're talking about, for the ESRD population, for Medicare, this is Medicare expenditures, it's a little over $30 billion a year. So Medicare essentially spends about 6 to 7% of its budget in the ESRD space, even though the ESRD population is less than 1% of Medicare patients. So what about CKD? So this is data from NHANES. And again, CKD is very common. So you saw Claudine say about 1 in 10, and that's the number that we often throw around to be kind of on the conservative side. If you look, and this is by stage, so a couple of things here is that, and this is in different cohorts. So over time, there's been an increase compared to the early 90s, but it's probably stabilized here, and some of you may have read the recent article in Annals of Internal Medicine that looked at this in a fairly detailed way, and it looks like there may be a stabilization in recent years. However, it's still stabilized at around, say, 14% or so, which is about 1 in 7 patients, and this is the adult population. This is awareness of CKD. So this is in NHANES. So it takes patients with various stages of CKD and asks them a question about, are you aware that you have weak or failing kidneys? And even in stage 4, which is quite advanced, it's still, less than half say they know about it. And some people there's been work at asking this different ways. Some people would say, well, maybe it's because the question's not right. But even if you ask it various ways, you don't say weak or failing kidneys. You say kidney disease, protein in the urine, something like that. It's still low. Doesn't change this by much. So what about health system data? So health system data, so the NHANES goes in and by design gets a measurement in everybody. So you can get the true prevalence of disease. The problem with health system data is that you have to leverage what data is there for you. And often that data is there for clinical reasons or for billing reasons. It's not there by design to go out and find cases of kidney disease. So there are issues and limitations with that. If you go by diagnosis codes that are in billing claims, they're decent specificity, meaning that if it's there, it's probably that patient probably really does have kidney disease, but there's also low sensitivity, meaning that you miss many of the cases and probably you miss certainly the early cases. So what about if you do have biochemical data? What do you do with it? You have multiple serum creatinine measurements. Do you, in order to call somebody CKD, do you impose that 90-day requirement? That means they need to have had their creatinine measured multiple times. The moment you do that, you're picking somebody who's probably sicker than usual because they're getting their labs measured more frequently. So now you're only looking at the sickest population. So how do you handle that? If you're trying to track within the healthcare system what proportion of your patients have kidney disease, what do you use as your denominator? Do you only take the people that were tested and say how many of those have kidney disease? Again, the same problem there is there's a reason why they were tested. So how do you do it? And a lot of the data we do, we kind of just present the entire population of people who are using the healthcare system, whether they're tested or not. And that's how we calculate prevalence in a lot of the data we do. Issues with race. A lot of healthcare systems don't collect that information, or at least don't collect it consistently, and it's needed in the GFR estimating equation. And then there's the whole issue of the eGFR equation. In the time that we've been working on these projects, we've changed from the equations from the MDRD to the CKD EPI formula, and issues of lab standardization. So there are problems. So nevertheless, we proceed and try to present the best we can. This is Medicare data, and this is based on codes. And what you can see is that, well, if you go based on codes, there's an inexorable kind of rise. But remember that codes are capturing not just the true presence of disease, but also just the awareness of disease. This is in the VA data with biochemical data. And this I'm just giving as an example to show how you define CKD. You can get very different numbers. So here we use a liberal definition. So just one value of creatinine that shows a reduced GFR, just a dipstick that's positive or a claim, and you can get as many as a third of the VA population. And the VA population is older and quite a sick population, but up to a third will be called kidney disease. If you use a more strict definition requiring chronicity, requiring a quantitative measurement of protein, then it's about, it's less than half of what you capture here, about 1 in 6. So how you define it is really important in terms of who you identify. So, quick overview of some trends that are perhaps some areas to focus on. So, one is urine albumin testing. So, urine albumin testing is really important to try to quantify the prognosis of any patient with kidney disease. It's certainly explicitly something that, many providers know to track in diabetics, but it's also important in anybody with kidney disease. And what we see is that, and these lines, so this is patients who don't carry a diagnosis of chronic kidney disease. This is patients with a chronic kidney disease diagnosis. And there's been improvement over time. But even in diabetics, it's about 40%. And if you've got kidney disease, a little better. But the rates are still fairly low. And there's some nuance to this. So it doesn't mean that we necessarily expect this to be 100%. But it does show that perhaps there's room for improvement there. And we know this is an important aspect of identifying patients at risk. And this is VA data. And I just wanted to show it to show how consistent the trend is, even outside a completely different healthcare system. And I can't show you the Clinformatics data just because it's going to be in the report for the ESRD is coming out later this year. So I can't release that data yet, but it's essentially the same trend as well. So completely different populations, same kind of trend. So I think this is an area that may bear attention. The other thing is this is VA data showing use of angiotensin inhibitors in diabetics with chronic kidney disease. Many of these patients, probably should be on one of these agents. Probably not 100%, but it's about a little over 60%. And again, the question is this something that you can use data to track? And this is something for which we have clinical trial evidence of benefit in the right patients. Vascular access use. So this is now getting closer to the ESRD end. We have a lot to do there. What we'd like is for people to start dialysis with a fistula. What you've got in this top line is people with a catheter. So vast majority of patients hit dialysis with a catheter, and we've hardly moved this line in a decade. And a lot of that probably relates to, preparation. So a lot of it comes before they even start dialysis. And this is just an idea of pre-ESRD nephrology care. This is pulled off the 2728 form that's submitted for Medicare entitlement. And what it shows is that, less than half of patients have more than 6 months of nephrology care prior to starting dialysis. And you see a gradient. The longer they have care, the more likely they are to have a fistula. It goes down as you have less and less care. So to summarize, I think I can say that there's a lot of room for improvement in the care of patients with kidney disease. I think one of the themes is that it's important to focus on those upstream efforts. That's likely to be where we're going to be most impactful. By the time people get to dialysis, a lot of the damage is done, so to speak, and you see how high the mortality rates are, although even there we've managed to move the needle. If you're going to focus on those upstream efforts, it's likely that primary care physicians need to be playing a big role in that. A lot of patients with early stage CKD or even just risk factors for CKD, they're going to be managed by primary care physicians, not by nephrologists. So figuring out ways to engage the primary care physicians and thinking about ways in which nephrologists and primary care physicians can work together is going to be really important. And then finally, as you can see, you can use various sources of data to help kind of get a snapshot of what's happening. And I've shown it in terms of the function of these projects has been kind of high level, national level. But obviously, I think part of the goal of the project that Claudine and others are working on is to looking at a more, at a healthcare system level. And that's going to require, other challenges potentially. So I just want to acknowledge Dr. Rajiv Saran, who's the PI on all the projects, our staff at Keck, and the funding from the NIH, CDC, and the VA. Thank you.
We've got time for a couple of questions. We've got two people who are manning the microphones, so raise your hands, please.
Bill Doms, Nephrology Associates. Thank you for coming and thank you for your talk. I appreciate you putting in the data about urine albumin testing at the end, because that is really disheartening and it's a huge opportunity for improvement. That number you said, 30, 40%, that needs to be 90% or greater. Some of my fellows may be in this room, but they will know that when they work for me, that number's got to be 100%. It's not about staging as much as it is about prognosis. So, thank you.
Thanks.
Thanks for a great talk. I'm Liz Brown. I'm a family physician, so I appreciate the discussion about the role of primary care. Are there any examples that you know of where the primary care and nephrology connection is really robust? Because I know that there's, it can be difficult to get a patient in to see someone, and in some ways what we need is ways to communicate that don't necessarily need office visits. Is there anywhere in the country that's doing that really well?
Certainly, there's been some work on multidisciplinary clinics, although those again seem to, make the main focus on, it's still the hub is the nephrologist, and then kind of bringing in the tie with the primary care physician. I actually think this is, an area of substantial importance, and I think it probably needs a lot more work. I've mostly read the literature on some of the challenges in kind of implementing this kind of thing, and everything from primary care physicians having challenges with being able to in some places really find nephrologists to be able to refer their patients to concerns about nephrologists kind of taking over sometimes the care and not really feeding back to the primary care physician. So I think this is an area where that kind of work, it needs a lot of, I think, another area for improvement. I don't know if there's anyone who knows about a model that works well in this room, sorry, but I think this is a crucially important area, and it's going to be a challenge as well.
Maybe we can build it in Delaware. Thanks.
Great.
Good morning. My name is Jeanette Reed-Jones. I'm an RN, and I have a question about the adjustment for the Hispanic ethnicity. I just would like to know what that's all about.
Okay, so we're going to talk about those issues. Dr. Cruz will be talking about disparities later, and she's offered to try to address your question in more detail.
Good morning, everyone. My name is Shay Scott. I'm with Henrietta Johnson Medical Center. And being as though we're a federally qualified health center, we actually do the family medicine. So there's an opportunity to do telemedicine, I think, potentially provider to provider, not necessarily provider to patient, but that might be a new area of research that in Delaware we might be able to head up.
Yeah, the telemedicine, I think, is a great idea. I think one of the issues, and it's funny, it's actually fairly old technology. I used to work in a hospital where we contracted actually with a prison system in Texas, and we were doing telemedicine. That was about 15 years ago. I was doing nephrology consultations. to help providers and see patients in that context. I think it's an area of growth, and the VA certainly has programs in place. I think there's issues around, again, figuring out the billing issues with it, and making sure that care is not compromised. So I think there's a lot of interest in it. It's one of the ways certainly that there can be better outreach to patients who may have a hard time traveling to a nephrologist for certain areas, as well as you mentioned, kind of provider-to-provider consultation. So getting back to the idea of nephrologists interacting with primary care physicians.
We have time for one more question.
Good morning. Thank you.
Someone? Sorry.
Amy Pollock, caregiver. My husband's recently diagnosed with heart failure as well as chronic kidney disease, and we're about 9 months into the whole process. So there's a lot going on in a very, in our opinion, in a very short period of time. And I find that the heart has definitely taken a precedence, but the knowledge of what chronic kidney disease means, especially to him, has been limited. All of the doctors we've dealt with, primary and nephrology, have been terrific. And he's also a patient with a VA. So trying to coordinate all three of them, getting enough information to know what to do with any of it, has been my difficulty. I don't feel that anybody is telling me everything we need to know. We had a cardiac MRI done, and he was 2/3 of the way through it when I found out they had given him a dye in order to do the work. And they threw the doctor under the bus and said, well, he should have told you. It's like, no, you should have told me. So some of the information is just not coming to us on the patient side of the equation, and I think it's all there. I think everybody knows what it is, but I don't know if it's a matter of assuming that the patient's not going to understand it, or not being able to bring it down to that level, or not having good bedside manner. I don't know. But I personally would like for more information to be shared with us, more Q&A, so that we can get this information and coordinate it into what we're doing.
Okay.
Thank you.
Thank you for that comment. Okay, thank you.